The best, worst part of the conference is that there's so many amazing people to talk to, and you only get 15 minutes to go to the bathroom and get back for the next amazing speaker. You're slowly coming back. It's also hard with the sunshine. If anyone's from the Midwest, we haven't seen it in a while. It's true. All right, so as people are filtering in, if the people in the room could be a little quieter. Ray, I'm looking at you. Because I'm really excited to introduce the next speaker. Yeah, okay, thank you. I'm really excited to introduce the next speaker, who I actually met here 2 years ago. And I wasn't anxious at all about saying his name, but he gave me a little primer last night, so hopefully he'll let me know how he does. So I'm really excited to introduce Diarmuid Denneny, is how he said to say it. He is a professional lead physiotherapist at the Pain Management Center, the National Hospital for Neurology and Neurosurgery, University College London Hospitals, NHS Foundation Trust in London. That was a long sentence. Whew, okay. Clinically, he is an advanced practitioner physiotherapist, an independent prescriber, and he works in a MDT. What does that mean? A multidisciplinary team. I should have asked that before, sorry. With people living with ongoing pain. Diarmuid is interested in psychologically informed practice and the role for physiotherapists in supporting people who have pain and medication-related issues. He has published peer-reviewed articles relating to physiotherapy practice and pain, including a systematic review of trigger point manual therapy, a rapid review of automated outcome measures, and an observational study on behaviors of experienced physiotherapists working within a psychologically informed model. Diarmuid is a member of the Guideline Development Committee for the NICE Chronic Pain Guidelines. He is a module lead for strategies for the self-management of pain for the UCL MSc in pain management. He also has interests in the non-medical management of CRPS and is a committee member of the CRPS UK. So, Diarmuid, come on up.
Thank you. Thank you, Sarah. Can you hear me? Can you hear me? Is it on? Is it on? Hello? Oh, yeah, it's on. Hi. Thank you, Sarah. And thank you, Rajam, for accepting my proposal with my slightly controversial title, but hopefully it'll become clear as we get through this. So I came here 2 years ago, and it's really great to be back again. It feels like a wedding without the fights, so I really like it. Yeah, it's great fun. It's perfect. So just to start, it's probably helpful because I know loads of people want to come up and say hello to me, but they can't actually say my name because of all those letters put together in an order that doesn't make any sense. So if you think of Kermit and just take away the K and put in a J, that's kind of how you say my name, okay? So Diarmuid, yeah. So, and I should start by saying I'm sorry if you don't like frogs or green things, because there are going to be a lot of them in this presentation, okay? So I'm coming here not as an expert, not as an expert in education, but it is something I dabble in. I also want to shine a spotlight on people who are heroes to me, who don't often, I guess, own the reputations that I think they deserve. They've done a lot of work in this field, and so that expression, standing on the shoulders of giants, is something that I hope to do today with this presentation. I'm learning as I go along. It's all an adventure, and I'm going to share my story with you. I'm really lucky to be in a center where I get supervision from psychologists, and it's nice to have 3 psychologists, and it's really nice to follow Dr. Noel. Because this is all about psychology and how non-psychologists might be able to work with that. I'm from Ireland, but about 20 years ago I moved to London. And I now work at this place. It's called University College London Hospital, which is a very big teaching hospital right in the centre of London. I work in a pain management centre. It's a multidisciplinary team. I realise that could be confused here with other meanings for MDT, but basically on our team we've got over 50 clinical staff, so we have physiotherapists, we've got psychologists, we've got nurse specialists, and we've got anaesthetists, and we all work together. We take referrals, so we see people on an outpatient basis who have come from usually other pain centres, regional pain centres, where they deem their cases to be more complex and they'd like us to work with them. And we specialise in services like abdominal pelvic pain, neurological conditions, so like after stroke or MS or things like that. We do neuromodulation there. We work with people with hypermobility Ehlers-Danlos syndrome and facial pain. So we're a big central London centre. But I've been there for over 13 years, and is this an expression you guys recognize? Yeah? Okay, good. And I'm in a bit of a bubble. You know, I just think it's normal to just have a really difficult session and then just go and knock on one of the psychologist's doors and say, can I have a 2-minute debrief? And I guess over the years and speaking to people, I've realized that actually that's a real luxury. Clinical health psychologists who specialize in pain management are a bit as rare as hen's teeth. So, you know, it's great to have opportunities. So whoever is here, yeah, I'm sorry if you get lots of people approaching you after this. Before, I wanted to maybe get you all just to think for a moment about what you think the term psychologically informed means. So just what words come into your mind when you see this phrase, psychologically informed practice? And maybe just turn to the person beside you and just share a couple of those words. What comes up when you do it? Just take a minute and share some words with each other. What do you think when you think psychologically informed? Okay, a lot of talk. It's not talking about last night or anything else, just talking about psychologically informed practice. So I did this with Jackie, who's down the back. She's my partner in crime. We ran a workshop with a group of osteopaths in London last year, and we asked the same question. And I was able to use the tech better at that point. So we kind of these were the types of things that were coming up for people, and maybe you were discussing with your partner just now. But I think what's interesting is there are some words in there that, to me, still speak to this idea of stigma, and when we try to consider the psychological impact of pain. So in this one, you'll see psychosomatic mentioned, and hyperventilating, and hysterical, and susceptibility, and I'm not quite sure what they mean, but anyway. So that it's interesting, perhaps some of the misconceptions around what we're talking about when we're talking about psychologically informed practice. So this is Dr. Amanda Williams. She's a reader in psychology at University College London, and I'm really lucky that she works at our centre half a day a week, and she's been really supportive of me and the physio team. But I bring her up here to start talking about psychologically informed physiotherapy. And apologies, I'm a physio, so I'll talk about physio a lot, and I don't say physical therapist, sorry. But she and Vicky Harding, who was the lead physio at another pain centre in London called Input at St. Thomas's Hospital, 25 years ago they published this paper about applying cognitive behavioral therapy strategies or combining them with physiotherapy. So it's not new, it's been happening for a long time. And at our centre, we often start with people when we're trying to consider what a psychologically informed approach might mean by bringing up this hot cross bun. Have you come across the hot cross bun before? Yeah? So as a way of trying to think about psychological impact and psychological aspects, and again, apologies to the psychologists in the room. But as physios or physical therapists, often people assume we're just going to focus on the physical symptoms, we're just going to focus on behavior, activity, and exercise, and that we're just going to kind of do that in isolation, independent of what they're thinking and what they're feeling. So often we start by drawing this out and kind of highlighting why we might be asking them, some of the questions we will be asking, why we might be talking to them and interested in things that they think, hang on, I thought I was coming to see a physio today, not a psychologist. So the term psychologically informed physiotherapy was actually coined in that special edition of Physical Therapy in 2011 by Main and George. And they talked about psychosocial interventions. That's what we were referring to. But doing a rapid review of the literature, you come across lots of terms in the research that are used to broadly describe this concept of psychologically informed practice. So we might see the biopsychosocial approaches used as a term. We might see psychological interventions by non-psychologists, cognitive behaviorally based approaches, psychoeducation, pain neurobiology education, information giving, stress inoculation, or cognitive functional therapy, or pain coping skills. And these are all different terms that are under an umbrella that could be considered psychologically informed approaches. Another of my heroes, this is Professor Francis Keefe from Duke University here in the States. He has been tremendously supportive of non-psychologists developing their skills and teaching them and been very generous with his time. But in 2018, he published a paper that kind of looked to summarize some 5 key principles that one would think about in relation to psychologically informed approaches. Educational. So again, pain neurobiology education could be part of that. Looking at behavior change in terms of activity. Looking at thinking, what's coming up for people, and how they're dealing with that. Psychophysiological focus kind of refers to often relaxation type approaches and mindfulness, although I always point out that mindfulness is not relaxation necessarily. And then more, I guess, formal contextualized cognitive behavioral approaches, which might include CBT or ACT or mindfulness-based pain reduction approaches. So it's a really nice paper, and it summarizes what we might mean. Now, it was Valentine's Day yesterday, so I want to give you all a gift, a belated gift of our paper. So, so if you find me on Twitter, there's a pinned tweet, and there's a link to this paper, which is freely available for the next, I think, 43 days or something like that. But anyway, so the reason I bring it up is to humble brag. No, it's to, it's really to kind of talk about what I was interested in when I first started exploring this more, was that actually a lot of the literature is theoretically based. And I wanted to know, well, what does it actually look like? You know, what is happening? What are people doing when they are being psychologically informed? It sounds very mystical and very fantastical. So what we did, so again, being at University College Hospital, we're very lucky because University College London is right beside us, and there's loads of interesting minds there and great brains, and they often come to us to ask questions about, we've got this question, or we're thinking about that. Do you think you could help us, or would you be involved? So Professor Nadia Bianchi-Bertuzzi works at the Center for Human-Computer Interaction. And they were really interested in developing or looking at whether it could be possible to develop AI and kind of supportive tech for people living with long-term conditions and in particular pain. And she and her team were coming in and filming some of our clinicians as part of a different study. But by doing so, they were collecting a lot of rich data. So this study, this paper came out of that because this was, if you like, the data that they weren't using that I thought was really valuable, because it speaks to what actually is happening when we're working with people in this way. So what they did, they filmed 4 of the physios delivering a class, a regular class like they work. So it would be an exercise group or part of a movement group at one of the pain programs. And the 4 physios had ranged between 9 years of experience up to 17 years of experience. They all had done some form of postgraduate training in pain, whether that's Explain Pain type course or something else, but 3 of them had done masters in pain. And what we did was we looked at what they were doing and then mapped it onto the CBT competency framework that's been developed by UCL's Center for Psychology, and that's freely available online if you wanted to look at that. But we identified broadly 4 themes that were coming out here. And the first of them was that the physios, when they were working with people, they're developing a therapeutic alliance. And I know Maxie spoke last year really brilliantly about this, so yeah, thank you. So you all know what I'm referring to here. But what I want to do with this paper, again, what's I think different about this is a lot of it is taken up with just giving examples of what actually the physios were saying. So they were filmed for an hour, and then the film, a psychology researcher met with them for an hour and played the film back to them and paused it every so often and said, what were you doing there? Or why did you do that? Or what was the purpose of that action? Or why did you say that there? So as you can imagine, that could potentially be quite intimidating, but it was actually a really excellent opportunity to do some reflective practice. And so I wanted to just read these out. So I often try to repeat the actual words that people have said, to acknowledge hearing them, and to kind of mirror, I've heard what you have said, and reinforce that that's a helpful thing that they have said. So that's an example of kind of trying to build up the therapeutic alliance. The next theme was around reducing perceived threat, which might include, normalizing their experience. What you're feeling, those symptoms, those signs, they're normal. Lots of people who are living with pain will describe similar things. So participant D, these are the physios quotes when they were asked what they were doing. So when they're moving and stretching and they hear clicking, it can be quite frightening. So it's just to remind them that these are normal sounds. We'll have talked about what they are, what the clicking is, and what's going on in the body previously. So we don't go into huge detail, but it's just to remind them that it's kind of normal. So that's trying to normalize their experience. Another one, there's a bit of a myth that exercise has to be done in a certain way or it's not right. And actually there's a spectrum and there's lots of ways you can do it. So it's finding what works for you. It's giving you options. And then the patient or person can choose what works best for them. So what I'm hoping is what you're starting to see is there's nothing particularly rocket science in this, but it's stuff that perhaps we're all doing already, but it's just nice to see it, to record it. The third theme was around reconceptualizing beliefs and somatic experience. So some of the examples of quotes here from Physio B. Sometimes I might get to the point where we're just getting stuck. So I might go more into, how about we set up an experiment? Or how about you give an alternative approach and give this a go and just see what happens? It might be that that way is better than your way, or it might be that you like the new way. So just trying things out, offering choices to people. If we tell a patient, next stretch, you're going to have to bend forward, for example, you might already trigger off some ideas in their brains that go, oh, bending forwards is really bad. But if you just start doing it and then talk through it as you're doing it, there's something that says to them, oh, actually, I'm bending. That recognizing the achievement. The final theme that we identified was fostering self-efficacy that Dr. Knoll has already mentioned. The ultimate aim is for them to move with confidence rather than moving in the way that we want them to move, what the Physio C said. And this was when they were giving instructions in the group stretch. In a group where you're doing stretches in context, gentle is fine. So using that term, move gently. But sometimes in letters, I think the word, you just have to be careful in case gentle means be careful not to. So sometimes that kind of delicate balance between some of the messages we're giving explicitly versus what implicitly people are taking from them. So, this got me interested in how do we train physios? What do we do? And this paper from 2005 from Prof. Hay and the team looked at training physios to deliver a cognitive behavioral back pain intervention. And so I was interested in how they document what the training involves. And the physios in this, to be able to deliver this cognitive behavioral approach back in 2005, undertook a 2-day training, and that was supplemented then by some clinical tutoring and the reflective log, a treatment log. A few years later, this group referenced that and a few other studies and focused on the idea that actually skills and competencies to develop this are really important, and how do we support that? And started to question the idea of, is that possible in 2 days to develop the necessary skills and to maintain that essentially behavior change clinically? So this is another hero, Gail Sowden from Keele University. So I was speaking to her as part of getting more interested in this, and you may be familiar with the Start Back tool. It's like a questionnaire that clinicians can use to identify people who are at low risk, at moderate risk, or at high risk of developing ongoing pain and problems associated with that. So as part of the research to develop that tool, the impact study looked at the training for the physios who are going to be delivering the moderate and the high-risk treatments. And all of the physios, because they decided that a two-day course is simply not enough to give these people the skills that they need, the physios who are working in the moderate group were given a 3-day training. For the people who are going to be working with people who are in the high-risk group, they got an additional 6 days of training with a psychologist and a physiotherapist who specializes in pain. And then they had monthly group supervision for between 6 months and a year after it. So that ongoing input, opportunities to reflect, to bring up challenges. This is Dr. Zara Hansen from Oxford University. And I know, Sarah, you've retweeted this. I put it up. You might be familiar with an excellent resource online that's freely available, which is teaching CBT to non-psychologists to be able to deliver this best back program. And you can register online, and it's like a 6-week program. And it involves looking at kind of webinars and then some interaction through comments on the system. And at the end of this, people have the skills and the resources to be able to deliver this package, a treatment approach, which is very well researched and evidence-based. But I also wanted to speak to her about thinking how do we follow that up? How do we support people who maybe do this to be able to maintain any of the skills that they developed when they encounter difficulty and challenges? I'm going to change tack slightly now and mention the Physiotherapy Pain Association. So in the UK, we have the Chartered Society of Physiotherapy, and the Physiotherapy Pain Association is a special interest group of the Chartered Society. And I'm sitting on a chair there. That's my subtle way of saying I've taken over the role of chair of the PPA in the last year. And the PPA is one of the oldest special interest groups. It's been around for 25 years. We celebrated 25 years last year. And it was founded by, inspirational physios like Dr. Vicky Harding and Heather Munsey. It's had members including Louis Gifford, who some of you may have heard of, and Mick Thacker. So it's got lots of, giants in the field, really inspirational people. And more recently, Gail and Zara, who you've now met, have been involved in it. And they've been talking about how maybe the PPA, this organization, could support training and support mentoring and supervision for those physios who are not lucky enough to have those hen's teeth, the ones who are working in private practice or in outpatients and don't encounter psychologists, clinical health psychologists. So in the last year, we had our conference to celebrate 25 years. And I'm going to talk about that, but I also want to mention that it is possible, so this is a plug, you can become an associate member even if you're not in the UK. So that's just putting that out there. But the PPA put together in 2014, they published a framework document. And again, it's a shame I don't think this has got perhaps as much reading as it should have done. It was a lot of work written by some really great people like Dr. Martin Hain, Dr. Paul Cameron, and Sarah Wilson, and amongst others. And it gives, if you like, a framework from a newly qualified physio right through to an expert when you're working with people with pain. And there's lots of information there. The hope is to move this forward to look at a competency framework, but that takes a lot of work. Now, when we started to think about how we could support people, it then got us starting to think, well, how would you develop something? And then you start to dive into the murky waters of areas that I think I have a lot more reading to do here around behavior change. So again, I mentioned that working at UCLH, I'm right beside UCL, and the Center for Behavior Change is there, and Dr. Susan Mickey and her team. And I was speaking to the deputy director. I contacted him, Dr. Paul Chadwick, and just said, I'm really interested in training clinicians. A lot of what we look at on behavior change is around, working with people living with pain, for example, in this instance. But I'm interested in how we train clinicians, and I'm wondering, where could you direct me to the literature, or what I could read to understand a bit more about how we maintain the changes? What's the best way to do that? So he got back and said, well, actually, there isn't that much published on this. Maybe have a look at the habit literature, which I had actually started to find myself anyway. And I suppose, I've got this question. I did warn you there's a theme, isn't there, Kermit? I was interested in, it's great learning new skills, but when we're maybe on a Friday afternoon and somebody comes in with a really, really difficult life story and situation, and you're with them, how easy is it to apply some of the new skills you've been developing? And especially how easy is that if you're in isolation, you don't have people to perhaps, knock on the door and say, can you help me? And it does seem that when we encounter stress, unless we have practiced the new skill regularly, we are more likely to revert to old behaviors. And I just think that's interesting when we think about trying to work in a way that might not be a way we're particularly comfortable with starting off. And so then I go further down rabbit holes and start to think, okay, well, let's think about change theory. And I know it came up for those who did the motivational interviewing workshop. And thinking about us as healthcare professionals and where we might be on this wheel of change. So we might think, oh, that sounds like an interesting approach. Maybe I'd like to know more about that. And I start to look up, where are the courses that I could do to develop my skills in that? And then we go away, and then we have to try and apply these regularly. And what I think we sometimes forget is the risk of relapsing, or going, okay, this is a bit challenging now. I'll do some of the stuff that I'm more comfortable or more familiar with. And that's human, isn't it? It's perfectly natural to do that. And that's when maybe we need a support. We might need supervision and mentoring. And there are different ways that we might access that. And I guess what I've been observing is that, it's great, as Rajam said right at the beginning, events like this are great ways to have those fireside conversations and in a safe space, and to be vulnerable and to talk about the challenges and the difficulties. And that got me thinking about the wonderful world of social media where everything is amazing all of the time. Living your best clinical life on social media. And and I thought, actually, I think it's a bit darker than that, social media. Sometimes, I love that, I love him. Sometimes, well, how often do you see people put up I had a really difficult, I really got stuck, it went completely wrong. And even if they do, how can you really reflect on that and work with that and retain confidentiality and all the other things that we need to do? It's not ideal, is it? And when it was Zara Hansen who brought this up with me, and I thought, yeah, actually, that's true. Often you'll see people offer solutions. Jump in. Well, have you tried this or do that? And again, if we're thinking about the skills we're trying to embody and develop with people, that might not be the most helpful way to do that. It's not always the case, though. Yeah. So with all of that in mind, the Physio Pain Association, we had our celebratory, conference last year in Glasgow. It was wonderful. And the first year that the Physiotherapy Pain Association ran their conference, their guest speaker, their keynote was Patrick Wall, who some of you may have heard of. And he was incredibly supportive of the Physiotherapy Pain Association. So we thought to honor him, who we would like to invite somebody to deliver the keynote for the conference. And speaking to Heather and Vicky, who are the founding members, and trying to work out who would be, you know, the rock star that we could get that deserves that opportunity to speak. And we invited Professor Francis Keith, Frank as I'm going to call him because it's easier. But and I was so delighted that he was really willing to come over to talk to us. And we don't quite have, Glasgow isn't quite the same as San Diego in terms of being able to sit outside in February and, you know, drink a beer. It's not quite the same. But in the after conference drinks, just sounding out some ideas with Frank around all of these thoughts, all of these ideas that were going through my head and the PPAs around how do we support people and how perhaps could we look at training in a different way. And Frank has done a lot of work, a program of training of physical therapists and occupational therapists at Duke. He's also doing, I think he's delivered the training in Kaiser Permanente, and he's doing some projects with Australian non-psychologists in delivering training approaches. So he's got a lot of experience in different ways of working with people and training them. And I was like, I really want to look at how our association can support people who might not immediately be attracted to a pain physio group. You know, the people who, you know, part of that is around us broadening our net, being more inclusive. And the reality that pain is not just something that you see in a pain management center. It's across all the different disciplines, all the different specialisms. So I was like, I've got this idea, something I'd like to do, Frank. I'd really love to pick your brain. It's around maybe some kind of online thing. Instead of doing it in 2 days in a concentrated way, we'd like to think about how we could, you know, maybe do something over a period of a few months. And he was so enthusiastic. Great, I'll be part of that. Can I help? I was like, wow, yeah. If you're willing to, that would be amazing. So we decided that we were going to use Zoom. Other web platforms, other video conferencing platforms are available, by the way, but we use Zoom. And it reminds me a bit of this if you use Zoom and you're doing it with lots of people. It's like all of the little boxes and you can see everybody waving at you. It's great. So what we did is we put a flyer together. We tried to make it reasonably priced and affordable. We tried to find a time that would be after work so that people would be more likely to be able to join in who are working clinically. We wanted it to be short, you know, an hour long each time. And we were going to focus on, well, some of these skills, some of these psychologically informed skills. Yeah, and so we tried it out before Christmas, so between September and December, we ran it. We had 12. We had a mix of people who work in pain centers, and about half are people who work in outpatient musculoskeletal services or independently in private practice. So there was a nice mix of people on the group. And I can't present the data yet because we are looking at that, sorry, but it's looking interesting. But off the back of that, I'm aware that it still ends after 8 weeks. And so our idea has been to say, well, okay, now let's start to do a peer supervision meeting once a month where you can check in or not, and you can bring along cases. And we've chosen to use another hero who you'll be meeting next year, which is really exciting, Dr. John Lohner. And we were lucky enough that John delivered some training with us last year, and he introduced me to this approach of peer supervision, called a reflecting team. And you can Google this article, and it's really, really simple, straightforward way to deliver it. It's very effective. And we thought that could be a nice model to try out in a monthly supervision online session. Some feedback after the first one. I've just after dissing social media, I'm aware of the irony of now putting a tweet up there. But an email from another participant who works in MSK, or musculoskeletal services, about how they found it really interesting, really supportive. So the hopes, the plan is to continue monthly and hopefully see it grow. And what I was interested in is speaking to Gail Sowden, again from Keele University in Startbag. They had used a similar model with their peer supervision, although they did it face-to-face. We're now doing it online on Zoom. So I'm bringing this up to start to think about how do we move it forward. And part of that was around thinking about developing training that could possibly be accredited, that could be standardized, and that could be accessible and realistic for people to do. And then I started diving into the complex intervention literature, and that's fun. Basically, I found this framework, which is really helpful in terms of thinking about how to design a new training package. Thinking about who, and in this case, we're thinking about non-psychologists who want to develop these skills. Thinking about the barriers, what's making that difficult, and there can be a whole range of barriers, from affordability to, I can't take time off work, I'm in private practice, it costs me money if I'm not working. What would support people? Well, maybe it's more accessible to do it online, to do it for shorter amounts of time, but more frequently, to drop in and out as I need to. Thinking about what the actual components will be. And so the training that we delivered, and Professor Keefe would be very keen for me to stress this, with our group online training, before participants took part, we got them to do a survey, which included several vignettes. So we had some great actors from the PPA who did vignette scenarios of challenging cases. And we kind of did that because we wanted to get more of a sense of what people are actually doing clinically than they might report on just a question, or what do you understand by type of question. But we also used outcomes or measures of anxiety for the clinicians, and affect, the PANAS, to see how much they're aware of all the different emotions that may be present for them. And so using that survey, we kind of tailored the content. And we also checked in with the group halfway through. How's this going? Is there anything that you would like us to focus on? And the biggest thing that came back from that was, well, what do we do when we're stuck? What do we do when we encounter a challenging situation? So most of the remainder of that online training was about dealing with those situations. But we had started by introducing quite a detailed concept around functional analysis, really analyzing the situation to work out and understand what's going on. And we were able to use that then ourselves to work through difficulties or challenging situations. There was a lot of emphasis on doing and being, on real play rather than role play. So, everyone was invited to bring situations that are personal to them, that they would be willing to share and to work through those as part of it. Everyone had home practice each week. And we place a lot of emphasis on reviewing the home practice. And again, for the psychologists in the room, apologies, you will know all of this. But I think sometimes it's about reminding ourselves of the simple things that we can do. If we do them well, they can be very effective. So, off the back of this training, we've been approached, and this feels like a gift horse, and I'm still waiting for the catch in this, but we've been approached by the Health Innovation Network, which in the UK there's about 13 what are called academic health sciences networks, and part of their remit is to try and encourage better quality healthcare delivery by translating research into practice. And perhaps somewhat serendipitously at the time that we were delivering this training, they were doing some separate work. So this is the case, isn't it? Always lots of different groups doing similar things and sometimes not aware of that. But they're doing some separate work on looking at how could they develop their musculoskeletal physiotherapy team to support people with back pain in this case, who also might have mental health problems. And it just so happened that the Q Improvement Lab had put out a call for people to look at this and an opportunity to apply for grants. And so they've done some focus group work with patients and with physiotherapists in the South London area to try and understand a bit more about what the needs are. And I imagine, well, I was going to say, what do you think the biggest thing that clinicians come back with when you talk to them about delivering psychologically informed approaches? What do you think they come back with as being challenging? It's confidence. A lack of confidence is the big thing. And that's not just physiotherapists, that's general practitioners, physicians, it's all clinicians struggle with this. So what we want to do is look at it, how we might support that. Anyway, they approached us saying, oh, we see you've just delivered this training online. We're interested in doing this. Would you be interested in collaborating with us? And we're going to apply for a grant and see if we could look at this more systematically and develop something. And I was like, yes, where's the catch? We have a project manager. They'll do it. They'll do all of the work that I don't like doing, the filling in forms and applications and all those kinds of things. And we just found out just at Christmas that we've got the grant. So we're about to roll this out. We're going to, in March, have a 2-day workshop where we look at developing this, and I'm really excited. We have people with lived experience are going to be part of that group, as well as clinicians, to try and develop the training for St. George's Hospital, which is another large teaching hospital in South London. And once we've delivered that, we will use the data we gather from that to adapt or to tailor it to then deliver it again at Kingston Hospital, which is another hospital near there, to the musculoskeletal physiotherapists. The hope is that by doing this, we start to develop something that we can then look at a wider rollout and that is accessible and that can support people. I was trying to find a Muppet Show adventure, because it's all an adventure, and it's a little bit like, where are we going with this? What next? Well, as I said, we're hoping to write up the data on this, because I think it's really, well, maybe I'm biased, but it's very interesting. And I think it's the stuff we don't often see published and understand more about that. And I've got this peer groups, and I suppose for me that's a nub, is how do we set up groups where we can support ourselves? What options do we have available to us to do this? And it may be, you do a 2-day workshop and you connect with 3 or 4 people and set up, we could meet on Zoom once a month, and we could use the reflecting group model, and we could use that and see how we go. That could be an option, which might be accessible for some people. We could look to collaborate. It's all about collaborations, isn't it? And connecting and seeing, where we go with this. The hope, as I said, the Health Innovation Network have got a strong record of developing complex interventions and rolling them out nationally. So they developed Escape Pain as one example of an exercise program for persistent knee pain. So that's really all I have to say. I just want to say thank you again to Rajam for inviting me, and thank you for listening. I'd be really interested in your questions, and now you know how to say my name, come up and say hello, especially if you're interested in this and doing any work. Thank you.
Thank you very much. I really loved all the Muppets, actually. Okay, so questions. Let's see here. So this is from Jeff Bostic. Thank you for your talk. Given the full curricula and pre-licensure training programs, what are 2 or 3 key ideas you think pain educators should focus on to help students begin to develop knowledge, skills, attitudes in psychologically informed practice?
I'm just saying the last word, Sláinte, yeah. Lovely. Yeah, good question. I think for, is it undergraduate or, so you might need to translate this for me in terms of the difference between, is this for qualified physical therapists or people who are
I'm not sure. It says pre-licensure training program, so perhaps before you're a licensed physio.
Yeah. So Obviously, the most important thing is to have those opportunities to do the clinical placements and to work with supervisors and mentors who have that experience. So that's in place, right? You're already doing that. If not, it's about identifying where are my local pain services. Where are they? And if they're not local, could you reach out and contact somebody online, an email, and identify somebody who perhaps may be willing to offer some mentorship or just to chat with you about it. It's coffee is always a good place to start. I think, look, the Physiotherapy Pain Association are trying to lobby in the UK that we have more time at undergraduate for pain education, and I know there are some educators in the audience, and we know that there's a lot of pressure on the curriculum and what they have to include. So it is difficult, but it is something we're chipping away at slowly to raise awareness and to try and increase that aspect of undergraduate training. And I think for me, it's all about identifying people who have experience, whether that's contacting psychologists in your region or physiotherapists who have worked in pain services for a while. Just reach out.
Awesome. Yeah, ask for help, because I know that's certainly something that's challenging here in the States with our billing,
right,
and how we try to teamwork and refer appropriately. But then, so we don't have another question, so I'll ask. So we have some psychologists here in the audience,
mm-hmm.
and doing like the psychologically informed PT, do you, like in those classes, or do you have any suggestions as to like when it starts to be not my scope? Like when is it like, like I know some words, but also this is not what I can help with?
Thank you. You've been reading my slides, haven't you? That's a great question, and I should have mentioned this,
I
actually.
wasn't, but...
So we did in that paper, which you're free to download and read, we talk a bit about this, that there is a concern amongst physiotherapists around recognizing when is it outside our scope. And actually, often it becomes quite clear to people quite quickly, that's outside my scope. What may be happening is actually people, because of a lack of confidence, clinicians might be saying, I can't really deal with that, when in fact, if they had the psychologically informed skills, they may be able to deal with more of them than they realize. So we're often more cautious about saying, actually, I'm not saying that, but if someone starts crying, I need to refer them to my colleagues, the psychologists, because they're really upset, when actually we may be able to deal with that. So, we kind of comment on that in the paper, how physios are quite good at identifying, almost to the point of reflecting a lack of confidence in being able to manage.
Since there's still not another question, I'll actually keep this conversation going. Is what's interesting, so I actually work in an interprofessional clinic, primarily student-led. It was interesting when the psychologists were kind of like, look, so they do anxiety and depression screening coming in. They're like, we'd kind of like to stop screening the PT patients because we keep getting false positives. And I was like, what's a false positive on an anxiety and depression questionnaire? And it was actually, they felt that it was really tied to their physical symptoms, like what they were presenting for. So I think I'm really excited for your paper, which is on the Twitter feed and on the app. Thank you, Sandy. So that you can check that out, because I think it goes both ways. I think sometimes we're like, oh gosh, I don't know that this is my business. But then also I think on the flip side, people become anxious and perhaps depressed because of things that are being perceived as just physical.
Right.
Do you know what I mean? So it's that interdisciplinary, interprofessional. I'm really excited to see that coming out more with you.
Yeah.
So, okay. More questions? Time is an issue for implementation in the U.S. Any thoughts on the time this takes to actually do in practice, and how do we get paid for it? By Sandy Hilton.
Thanks, Sandy. I don't think it needs to take a long time to, approach somebody in a psychologically informed way. And there's a really nice example of in the BMJ Open on brief interventions, for example, to deal with distress in a GP appointment in the UK, where they have about 7 minutes, and there are things that you can do and you can apply. So it doesn't need to take a lot of time. It's more a way of working with people. than an actual treatment. How do we get paid for it? That's a good question.
It's an unfair question.
Well, it's I'm not sure I understand fully, because I guess it's not. You're still delivering physiotherapy or whatever treatment you're delivering. You're just delivering it in a psychologically informed way. So your treatment, however you charge, that shouldn't affect that in any way at all.
That was a beautiful answer for what she was trying to stir the pot a little bit.
All right.
Which I really love. And here's a great question from Jim Stark, which is, are your Zoom classes / training still available and open?
Oh, yeah, thank you. The plan, and actually I'm quite excited about this, speaking to some people, is to look to the PPA, the Physiotherapy Pain Association, would like to develop a group of experienced mentors / supervisors who will be willing to, once a month, join an online Zoom. And people can come, and using that model, the group reflecting model, it's a really nice way for people to bring cases, and then the group collectively vote for the one they would like to focus on. So the short answer is, currently, because we've literally just finished the pilot and we're starting this monthly, but the plan will be to roll that out. So keep an eye out. Keep an eye on the Physiotherapy Pain Association webpage. Consider being an associate member, and then we'll keep you up to date anyway, yeah.
That link was also tweeted out and is on the list on the app. So you can check it out if you're like, I just need to click. It's there for you. Okay, now we have a question from Uchenna Osai, right over here. How do you address implicit bias in the training of students and clinicians of psychologically informed physiotherapy?
Well, that's a great question. So I mentioned part of the pre-pilot that we ran was a survey, and some of those were like the PANAS, which is looking at them bringing awareness to what they're bringing to the table, I guess. And as part of the training, we were, so for example, in the second half of the online training, this idea of getting stuck, we would do functional analysis with people to really analyze that, to think about what's going on, what's been happening in their lives and their situation before, what are they thinking, trying to bring awareness to any biases that may be present and may influence their experience of working with somebody in that moment. So it feels like it very much is part of the approach is to bring awareness to what you're bringing to the table, if that's answering your question. Yeah, but great question.
And then we're going to move down the line over there to Jamie Lowy, who's asking, how often does your team reassess the psychological screens for issues like anxiety and depression to determine if treatment strategies need to change?
So where I work, we use the HAD, the Hospital Anxiety and Depression Scale, but we tend to use it as an outcome measure pre-post. We don't really use it as screening because I guess, again, I'm in that fortunate position in my bubble of working in a team with psychologists and psychologically informed clinicians that we would be assessing that while we're working with somebody. But how often should you reassess in kind of an outpatient setting? I think certainly you're going to screen at the beginning, but if you're not helping somebody to move forward, maybe that should be starting to flag up. Actually, is there more going on here? Do I need to check that again? It's not going to be a black and white when you should do it. It's going to be more about how you're getting on, I think.
Excellent. So I think the only final question we have is from Dr. Neil O'Connell. And it is, are you willing to give us a rendition of It Ain't Easy Being Green?
No. If you had asked for the rainbow song, I might have said yes, but no.
Okay, so then we will close this session. Rajam asked, actually, so she wanted to see about people getting up and moving around. So we wanted to challenge you a little bit, and we'll do a different challenge over lunch. But at the World Congress of Abdominal and Pelvic Pain, Sandy Hilton came up with the idea of like just a movement nibble, a little movement minute. So we're actually going to pull up a little bit of music before you go. And then I already asked him, Neil said he would kill everyone in the room if I did this to him, but I got permission. So everyone just stand up for a second, because we know that movement is, pretty darn good for a lot of things. All right, so just for a minute. Okay, so I actually kind of like all the movement. You can get your arms up. And then most of you who know me know I'm also a pelvic therapist, and we don't move them enough. So here's what we're gonna do. I'm gonna get you later. So just start a little. You don't even have to move your feet, so you don't have to say I'm tripping. Okay. And then legs straight, and just shift it side to side. Oh, you can do the arms too? Absolutely. And then we're gonna go around in a circle. So you're just gonna go around. So the top kind of stays still. Good. Just like you said you would. And then reverse it. And then we're just gonna do one more thing. So it's gonna be the same on the bottom, but you're gonna imagine you have a beautiful scarf. Good. Good. And then the other way. Ready? All right. All right. Beautiful. Go have your coffee, and we're gonna start back at 11:30.